Hi, my name is Melanie DiLoretto, and I and Sarah Campbell did our case report on gestational diabetes. Here is the basic outline of our presentation. We have included our narrations in the notes section of each slide if you would like to refer to them later. Today we will discuss gestational diabetes, its risk factors, monitoring and management, followed by a case study, relevant research and evidence, a conclusion, and a knowledge assessment. Gestational diabetes refers to glucose intolerance that occurs due to the onset of pregnancy or that is first recognized during pregnancy. For some patients, it can be viewed as glucose intolerance that was not detectable prior to pregnancy. After delivery, most patients will return to normal glucose tolerance, but gestational diabetes can increase the risk of future development of type 2 diabetes. Gestational diabetes complicates 5% of all pregnancies and is associated with adverse maternal and fetal effects. Mothers with gestational diabetes are susceptible to preeclampsia, gestational hypertension, premature rupture of membranes, cesarean delivery, future cardiovascular disease, and future development of type 2 diabetes. Fetal adverse effects include macrosomia, congenital abnormalities, hypoglycemia, and respiratory distress syndrome. Pregnancy is associated with increasing peripheral insulin resistance, which is more prevalent in the second and third trimesters. This is believed to be due to increased levels of placental lactogen, placental growth hormone, cortisol, and progesterone. Placental lactogen correlates with insulin requirements of parturients with type 1 diabetes. Therefore, it is highly implicated in the development of gestational diabetes. Maternal adipokines are involved as they help to provide maternal energy sources to the fetus as well. Risk factors for gestational diabetes include maternal obesity, maternal age greater than 35 years, polycystic ovary syndrome, maternal prediabetes, prior history of gestational diabetes, family history of type 2 diabetes, prior incidence of fetal death or stillbirth, prior delivery of a macrosomic infant, and vitamin D deficiency. Increased risk of gestational diabetes with age may be due to the reduced function of oxidative phosphorylation in pancreatic beta cells, the reduced ability of glucose uptake, and greater maternal stress of pregnancy. Patients with elevated BMI have increased insulin resistance. Patients with gestational diabetes are often asymptomatic. In the United States, it is recommended to screen all patients around 24 to 28 weeks gestation. If a patient is at high risk for gestational diabetes, she may be screened at her first prenatal appointment. Most screening is done via the glucose load test, also called the glucose tolerance test. There are two common strategies for gestational diabetes screening: the one-step strategy and the two-step strategy. The one-step strategy involves measuring plasma glucose at 1 hour and 2 hours after 75 grams of oral glucose is ingested. This test should be performed after fasting. Diagnostic criteria are a fasting glucose greater than 92, a 1-hour glucose greater than 180, or 2-hour glucose greater than 153. The two-step strategy is a non-fasted 50-gram oral glucose ingestion followed by a plasma glucose measured 1 hour later. If the 1-hour glucose test is greater than 130, then a 100-gram oral glucose test will be done when the patient is fasted. The 100-gram test has fasting glucose levels drawn as well at 1, 2, and 3 hours following the dose. The Carpenter-Houston diagnostic criteria is made if at least two of the following are true: a fasting glucose greater than 95, a 1-hour glucose greater than 180, a 2-hour glucose greater than 155, or a 3-hour glucose greater than 140.
With pregnant patients, we want to avoid peaks and valleys in their blood glucose regulation as much as possible. These patients will be more susceptible to drastic changes in the glucose levels due to stress and fasting and meeting the needs of the fetus. Making the patient the first case of the day, if possible, is ideal to reduce the time fasting and reduce the risk for hypoglycemia that can occur. Additionally, these patients require close observation of their blood glucose levels pre, peri, and postoperatively because low and high blood glucose levels can poorly affect the mother and/or child. In patients with labile blood glucose levels, the patient may require an insulin infusion in the OR with glucose checks every 30 minutes to maintain the patient between 110 to 180 milligrams per deciliter. Sustained blood glucose levels over 180 milligrams per deciliter are concerning for patients with gestational diabetes because it lowers the threshold for diabetic ketoacidosis, and the incidence of DKA during pregnancy is 6.3 per 100,000 pregnancies. DKA increases complications during pregnancy and can lead to fetal mortality. Ultimately, it is vital for the anesthesia provider to check the glucose levels with specific frequency to establish tight control of the mother's insulin requirements. According to Pani et al., back in 2010, it is recommended to monitor the blood glucose levels every 30 minutes while under general anesthesia with a pregnant patient. The safest form of anesthesia for a pregnant woman with gestational diabetes is regional anesthesia. Epidurals and spinals are both safe for this patient population and are a better choice of anesthesia compared to general due to their decreased risk for airway manipulation, the patient's greater ability at controlling their airway reflexes, and more stable hemodynamic response with concomitant fluid administration. However, regional anesthesia has been found to increase incidence of hypoglycemia in the fetus after delivery. General anesthesia is complicated by worsened gastroparesis in the pregnant patient with gestational diabetes, which increases the risk for aspiration more than in a healthy pregnant patient, and stiff joints that make visualization of the airway more difficult on an already difficult airway. Additionally, general anesthesia masks the signs and symptoms of hypoglycemia, such as tachycardia, restlessness, and irritability, making the provider more likely to miss low glucose levels in this patient population. It is vital that the anesthesia provider implement frequent glucose checks in this patient population to ensure treatment of high or low glucose levels to prevent injury to the mother or fetus. Autonomic cardiovascular dysfunction complicates both regional and general anesthesia techniques due to the sympathectomy that occurs with both. It increases the incidence of hemodynamic instability that is already seen in pregnant women. Pregnant women are already at an increased risk for labile blood pressure and heart rate due to their increased venous capacitance, changes in heart structures, and changes in cardiac output. With autonomic cardiovascular dysfunction, the patient has an overactive sympathetic nervous system and dysfunctional parasympathetic nervous system, which, when stunted by general anesthetics, causes rapid drops in blood pressure and heart rate. This population often requires concomitant administration of vasopressors and inotropes during induction to prevent rapid declines in blood pressure and heart rate. Anesthesia providers caring for a woman with under-controlled or over-controlled blood glucose levels who are expected to undergo general anesthesia should be prepared for rapid changes in hemodynamics by having vasopressors readily available and co-loading the patient with crystalloid. The anesthesia provider should also plan to intubate with a video laryngoscope and utilize RSI with strict cricoid pressure being held until the balloon of the endotracheal tube has been fully inflated. By utilizing the video laryngoscope, the provider is increasing the success rate for achieving endotracheal intubation on the first try, and strict RSI with cricoid pressure helps to reduce aspiration injury that can result in injury to the mother and/or fetus.
A 36-year-old Gravida 3, Para 1, abortions 2, living children 0, female presents to the emergency department at 34 weeks gestation with labor contractions. Once admitted to the obstetrical unit, the patient was found to be 5 centimeters dilated and progressing quickly through the labor stages. She was diagnosed with gestational diabetes at her 24 weeks gestation appointment and managed on insulin therapy. She reported feeling feverish for the past few days. Labs were drawn on the patient and continuous fetal heart rate monitoring was initiated. The neonate showed late decelerations and a decision was made for an emergent delivery. A C-section was predetermined to be necessary by her OBGYN due to infant macrosomia. Maternal lab results were found to be within normal limits with the exception of glucose at 410 milligrams per deciliters. The team determined the patient was also in DKA, likely due to an untreated infection. The anesthesia provider caring for the patient elected for general anesthesia due to the rapid deterioration of the fetal heart rate. An insulin infusion was initiated after the endotracheal tube was placed with a video laryngoscope and secured, and the fetus was removed. Once out, the infant's APGAR score was 5 out of 10, and the child was taken to the NICU with suspected respiratory distress syndrome requiring intubation complicated by hypoglycemia. The mom was transferred to the ICU for insulin infusion management.
Identifying a person with gestational diabetes early and initiating close monitoring, diet modification, and insulin regimen initiation is vital in preventing complications during the pregnancy. If gestational diabetes goes undertreated, it is predicted that the mother is at an increased risk for miscarriage and preterm labor related to polyhydramnios, which is a large amount of amniotic fluid that places pressure on the cervix and can trigger contractions. In the example of our case study patient, she had been started on insulin therapy at 24 weeks gestation. Polyhydramnios can begin to develop as early as 16 weeks and can progress even with the initiation of insulin therapy if the treatment is not adequately managing the patient's glucose levels. Gestational diabetes also increases the incidence of C-section. Like our case study patient, many patients with gestational diabetes are scheduled for elected C-sections due to fetal macrosomia, which is an infant born with an excessive birth weight. The infants born to women with under-controlled glucose levels often are too large to pass through the passageway of the birth canal. These infants are at an increased risk for getting stuck in the birth canal and can have nerve or shoulder damage from dramatic shifting required to pass through the birth canal. For the safety of the mother and child, women presenting with large fetuses are usually scheduled for elected C-sections. Like the infant in our case study, infants born to women with uncontrolled glucose levels are often transferred to the neonatal intensive care unit after birth due to increased incidence of hypoglycemia and respiratory distress syndrome. Hypoglycemia in these infants occurs because the increased glucose levels of the mother, while the fetus is in utero, results in increased production of insulin from the fetal placenta. Once a child has been birthed, their insulin production remains high, outproducing their glucose levels. The high insulin production also increases their risk for breathing problems, feeding problems, and seizures. Their risk for developing respiratory distress syndrome is believed to be related to their overproduction of insulin. It is thought that respiratory distress syndrome and the overproduction of insulin results in the delayed production of surfactant needed to keep the small airways open, causing eventual respiratory failure if interventions are not taken to improve the fetal ventilation and oxygenation. Finally, while our case study patient did not present with preeclampsia, this is also a risk with gestational diabetes. Both are diseases of the placenta and are related to abnormal hormone levels that trigger pathologies in the mother.
Diabetic ketoacidosis is a potential complication of gestational diabetes. It is imperative these patients have education of precipitating factors, risks, and manifestations of DKA. DKA is associated with increased neonatal morbidity and mortality. Morbidity and mortality rates are lessened with early recognition of DKA. DKA can present at lower glucose levels in parturients and also progresses much quicker. Potential causes of DKA include infection, vomiting, poor insulin management, and the use of corticosteroids. The patient in the case report reported fevers, which were likely the result of an undiagnosed infection, which warrants increased insulin requirements. DKA can cause fetal hypoxemia and acidosis. A viable fetus around 23 to 24 weeks gestation should have continuous fetal heart rate monitoring. If the fetus has a non-reassuring heart rate, the typical decision is to proceed with emergency delivery while simultaneously correcting the metabolic acidosis. The late decelerations seen in the heart rate tracing of the fetus in the case report resulted in the emergency C-section.
Gestational diabetes can have catastrophic effects for the mother and fetus throughout the pregnancy. Gestational diabetes affects women throughout the entirety of their pregnancy and alters the anesthesia provider's plan for the patient. If left uncontrolled, gestational diabetes can limit the woman's range of motion, result in preterm labor and birth, and increase rates of C-section. The anesthesia provider should be aware of how uncontrolled gestational diabetes impacts not only the mother, but the fetus, to ensure they are monitoring the pregnant patient throughout their surgery, that being non-obstetric or obstetric surgery. However, in women with early diagnosis and well-controlled diabetes, through diet modification and insulin regimens, can have an uncomplicated and healthy pregnancy and birth.
Which of the following is not a risk factor for gestational diabetes? The correct answer is D, first pregnancy. The other three options are obesity, polycystic ovary syndrome, and a maternal age greater than 35, and those are all risk factors for gestational diabetes.
True or false? General anesthesia is the best form of anesthesia for the patient with gestational diabetes. The answer is false. Regional anesthesia is the safest form of anesthesia in this patient population.